Hello everybody, in this video lecture we continue covering the respiratory system, so it's chapter 22 part 2. So we continue talking about conducting zone structure. I just want to remind you that conducting zone begins with nasal cavity and then larynx and trachea. So here's our larynx and the trachea. And then trachea bifurcates into right and left primary bronchi, and each bronchus enters the hilum of one lung. So hilum will be this area over here, where actually primary bronchi, blood vessels, nerves enter the lung. Also, right main bronchus is wider and shorter and more vertical than the left one. Even you cannot see on this diagram that much, but this would be the right primary on this side, right, until it starts dividing into this branch, right? So that's the right primary, and this one is left primary bronchus. And then primary or main bronchi, they branch into a secondary bronchi, and then tertiary bronchi, and then smaller and smaller branches that we call bronchioles. And each lobar or secondary bronchus supply one lobe. So it's right here. And because we have 3 lobes on the right, so 3 lobes on the right and 2 lobes on the left, then we have 3 main bronchi on the right side and 2 main or primary bronchi on the left side. Okay, then we have primary bronchi that divide into secondary bronchi, right, and then into tertiary, and then we have segmental bronchi. They divide repeatedly. Bronchioles are smaller air passages less than 1 millimeter in diameter, and terminal bronchioles are the smallest and diameter less than 0.5 millimeters. So if you look at this diagram again, we have that's our primary, right and left. Then shows in green our secondary, right? So over here, so 3 on the right and 2 on the left. And this everything that show here in yellow, this is our tertiary bronchi. So over here you can also see on this diagram lobes of the lungs. So that's a superior lobe, middle lobe, and inferior lobe. So we have 3 lobes on the right side, and this one is superior, and this is inferior lobe. So we have 2 lobes on the left side. Also, this fissure over here that separates the lobes, this is called horizontal, and this one they call oblique. So from bronchi through the bronchioles, we have some structural changes. So in this diagram over here, you see bronchus. And the bronchus, it would have inside, this is our mucous membrane, so that's a mucosa. Then this part, those are smooth muscles. This shown in green cartilage, right? And so when we're getting to a smaller and smaller bronchi, the cartilage actually became, this cartilage plate became smaller and smaller, and then it's absent in the bronchioles. We also see changes in the epithelium from pseudostratified columnar, it changes to cuboidal, ciliated, right? And we have also goblet cells. Also, relative amount of smooth muscle increases. So pretty much when we moving from bigger bronchi to the smaller bronchi and then to the bronchioles, we see more and more smooth muscles and less cartilage. Now we're moving to respiratory zone. Respiratory zone starts with respiratory bronchioles, then alveolar ducts, alveolar sacs, and alveoli. About 300 million alveoli for the volume of your lungs. And they are the main site for gas exchange. So the gas exchange happens inside alveoli. So you see histological slide and also picture of the alveolar duct. So here's our alveolar duct. And then we have this alveoli, right? And this is all called alveolar sac. So that's an alveolar sac. On this diagram, you can see how our alveoli supplied by blood. So we have lots of capillaries here, right? And that's where we have this gas exchange between blood and the air inside alveoli. So alveoli is surrounded by fine elastic fibers, and they contain open pores that connect adjacent alveoli and allow air pressure through the lungs to be equalized. Inside alveoli, you also would find macrophages. And macrophages, what they do, they keep the surface clean. Respiratory membrane. So I want you to look at this diagram and see that's the alveolus, right? So here's the alveolus. And alveolus is covered, the wall of the alveolus, these cells over here, this is simple squamous epithelial cells, right? So the whole alveolus is made of these simple squamous epithelial cells. And then we have a blood vessel or capillary, right? So here's the capillary, so all this stuff. And the walls of the capillaries are also made from simple squamous. We call it endothelium, right? It's also epithelial cells. Now, what is between them, right? Between them over here, basement membrane. So now, what is respiratory membrane? Respiratory membrane is alveolar and capillary walls and their fused basement membrane. So you will find alveolar walls, you will find these simple squamous cells, we call them type 1 cells, and also we will find some cuboidal cells, and we call them type 2 cells, and those cells secrete surfactant, and surfactant prevent your alveoli from collapsing. On this diagram, you guys can see this respiratory membrane maybe a little bit better. So we have this part over here, that alveolar epithelium, right? So here, alveolar epithelium. Then we have this wall that is capillary endothelium. And what we have in between them, I'm gonna put it in green, right in between, right? That's the fused basement membrane. Fused basement membrane. So that's our respiratory membrane. And also you can see these cells, like simple squamous cells, those are type 1 cells. Now, those are macrophages. You can see macrophages here. And I don't see, oh yeah, we do have type 2, right? So this kind of like green cell shown over here, the cuboidal, those type 2 cells that secrete this surfactant that keep your alveoli open. Lungs. Lungs occupy all the thoracic cavity except of mediastinum, and we have root, and root will be over here, where we have attachment of the primary bronchi, blood vessels, nerves, right? So structures that entering the lungs. We have costal surface. This is the surface where lungs kind of lean to the ribs, right? So that would be costal surface over here, right? And also lungs are lining on a diaphragm. So that's a diaphragm over here. So on this diagram, lots of labeling, but maybe we want to pay attention to this one. So this lining covering the lung, right, that's a pleura. And this is visceral pleura. Right, let me find where it's even here, visceral pleura. And now this lining covering the cavity, right, this lining covering the cavity, this is parietal pleura. And between them, we have pleural cavity, right? So let me take a blue. So here, this cavity in between, right, goes over here. This is our pleural cavity. So lungs have apex. So here's the apex and the base. So that would be the base. It also has hilum. So hilum will be over here where we have the root. And this is site of attachment of blood vessels, bronchi, lymphatic vessel, nerves. And on the left lung, you have this structure that's called cardiac notch. And this will accommodates for your heart, because your heart is, to the left, like 2/3. Yeah, oh, yeah, 2/3 to the left. So this space will be occupied by the heart. That's why the left lung is smaller. It only has 2 lobes, superior and inferior. And the right lung has superior, middle, and inferior lobe. So here it says over here, left lung is smaller, separated into 2 lobes by the oblique fissure. So actually, that's our oblique fissure right here. Right lung has 3 lobes separated by oblique. So here's our oblique. And horizontal. So this one is horizontal. And also your lungs divided into bronchopulmonary segments. So if you look over here and see all these different colors, those are bronchopulmonary segments. We have 10 on the right side and 8 to 9 on the left. And each segment is functionally and anatomically discrete, allowing a single segment to be surgically resected without affecting its neighboring segments. This is the significance of these bronchopulmonary segments. They're like functional units of your lungs. And if you resect one segment, let's say the patient has a cancer and this segment needs to be removed, right? It will not affect the function of other segments of the lung. Homeostatic imbalances. Atelectasis is the lung collapse, and it can be because of air or blood entering the wound. Let's say we have wound, and if we have air entering this wound, it would be pneumothorax. or it can be blood can enter this pleural cavity, or it can be plugged bronchioles and then alveoli will collapse. Blood supply. We already know about pulmonary circulation. So pulmonary circulation shown over here on this diagram, when from the right ventricle, blood flows to the lungs, right here and here. And this is where we have exchange. So carbon dioxide to the lungs, and we pick up oxygen, and oxygen is returned to the left side of the heart, and specifically to the left atrium, right? So we have pulmonary arteries and we have pulmonary veins. So arteries, remember, carry blood away from the heart. So pulmonary arteries here will carry deoxygenated blood, and pulmonary veins carry blood towards the heart. And in this situation, in pulmonary circulation, pulmonary veins will carry oxygenated blood. But we do have systemic circulation as well, and we have bronchial arteries that provide oxygenated blood to lung tissue, and they arise from aorta, and they enter lungs at the hilum, and then supply all the tissue except the alveoli, and then bronchial veins, they carry blood, systemic circulation, so they carry blood back to the heart. So let's look at next diagram. Right, so over here we see our pulmonary circulation. When we have pulmonary arteries and they reach in carbon dioxide, so deoxygenated, and pulmonary veins that carry oxygenated blood. So this kind of like opposite to your systemic circulation, right? Because usually arteries carry oxygenated blood and veins carry deoxygenated, but it's different in the pulmonary circulation. But you can see this part of the circulation, that's a systemic circulation. And then in the arteries, we have oxygen-rich blood, and in the veins, we have blood rich in carbon dioxide, right? So there's two circulation to the lungs, pulmonary and part of the systemic as well. Pleura. We mentioned pleura a little bit. Pleura is thin, double-layered serous membrane. And you look at this diagram over here, the lungs themselves, they're covered by visceral pleura, and the cavity covered by parietal pleura. And then space in between is a pleural cavity where we find pleural fluid. And this fluid provides lubrication and surface tension. We already looked at this diagram previously, so you guys can spend your time and look at all these different structures. You can pause the video and identify all the structures on this diagram. Now about some diseases. COPD, chronic obstructive pulmonary disease. And example of this would be bronchitis and emphysema. It's irreversible disease in the ability to force air out. So the patient would have hard time to exhale air from the lungs. Common features are history of smoking in 80% of patients, dyspnea or labored breathing, coughing, frequent pulmonary infections, and many victims develop respiratory failure and accompanied by respiratory acidosis. So hypoventilation, not enough air moving inside the lungs. So over here you can see our two major examples of the obstructive lung diseases, chronic obstructive lung diseases. that chronic bronchitis and emphysema. And emphysema, pay attention over here, emphysema, when we have breakage of the elastin in the connective tissue of the lungs, and because the elastic fibers are lost, the alveoli and bronchioles collapse, right? So instead of being nice and round, right, they collapse, right? And that what keeps the air in, right? So obstruction of air and air trapping. So asthma is another example of the respiratory diseases. It's characterized by coughing, dyspnea, wheezing, and chest tightness. And we have actually active inflammation of the airways that precedes the bronchospasm. So you see in this picture normal airways, then we have some maybe inflammation, right, asthmatic airway, and then when we have a spasm, you see how small this lumen is, and because the lumen is small, the air is trapped in the alveoli. So airway inflammation is an immune response caused by release of inflammatory chemicals. So asthma is autoimmune disorder when your own immune system attacks the bronchioles of your lungs. Airway thickens because of the this inflammation, and it causes bronchospasm. Tuberculosis. So tuberculosis is an infectious disease caused by bacteria, Mycobacterium tuberculosis. And you can see on this diagram that how this bacteria initially invades the lungs, and then it progresses into a hole. And this is formation of numerous cavities. So all these cavities are forming inside the lungs, and bacteria progresses through the all lobes over here on the right side. So symptoms include fever, night sweats, weight loss, racking cough, and spitting up blood, and treats with antibiotics. So it's 12 months course of antibiotics. And lung cancer. So lung cancer is leading cause of cancer deaths in North America. 90% of all cases are the result of smoking. And because lungs have different type of cells, depends what cells became cancerous cells, we can classify lung cancer into three most common types. Squamous cell carcinoma, the most common, right, 20–40%, and it starts in the bronchial epithelium. Squamous cells are epithelial cells. Adenocarcinoma, also about 40% of the cases. And adenocarcinoma start with the cells that secrete mucus, and usually in the peripheral lung area. And small cell carcinoma, about 20%, very aggressive type of cancer. Patient can die within weeks if it's not treated. And it's actually there is a special cells that are involved over here. I'll show you on the last slide. And it's usually originate in the primary bronchi. Also, small cell carcinoma, not only very aggressive, it's almost never found in patients who do not smoke. So this is the one that associated with smoking a lot. And on this last slide, you guys can see that because in the lung we have different type of cells, right? So here you can pause the video and see we have this neuroendocrine cell over here, and this is the one that give us small cell carcinoma. Now, if we have, let's say, this secretory cells or goblet cells, if they became cancerous, then we have adenocarcinoma. If we have just the epithelial cells, right? So here's our epithelial cells. If they became cancerous, we have squamous cell carcinoma. And your large cell carcinoma we didn't cover, but we have this cells over here that are lymphocytes. So here's the lymphocytes right there. They became cancerous, and it will be large cells carcinoma. So different type of cancer because different cells became cancerous cells actually. Okay, so that was our last slide. Remember to watch the first part, and good luck.